doesn't really, the pancreas does not have an encapsulating fibrous tissues around it, and that's actually really important, and actually a good thing. And that's why on CT especially, it almost sometimes looks like someone dropped a feather into the body, because there's no skin, as it were. Okay. Someone just had the blue screen of death. The pancreas lies slightly oblique. Now, students have the hardest time remembering that. That's understandable. So when you hold your transducer, you're going to be looking right in the middle of the epigastrium, and your transducer is going to be more or less on this line, like this. That might be slightly exaggerated because it's not very oblique, but it is slightly oblique, and that's kind of shown down here. The head is inferior to the tail. Remember, superior, inferior. So, or head to tail. The tail is more superior. The head is more inferior. And so that's why when we're doing transverse, we're not perfectly transverse. We're just a bit oblique, and that's what helps us get the entire image. I have two views drawn out here. This is kind of this is your textbook. Textbook view of the pancreas, and so we have left lobe of liver.
Sorry, Kurt. Sorry, Mr. S. I don't mean to disrupt you. What chapter are we on exactly?
Oh, I'm sorry. The pancreas chapter 7.
Okay, thank you.
Sure.
I think page 214. I think we're on page 214. I think, I don't know.
Yeah, right at the beginning. Your textbook view shows left lobe of the liver up here. The stomach is kind of squeezed in between the left lobe of the liver, and if we could see it, there would actually be there'd be a potential space in between here from like all the way through here. That's the lesser sac is in this space, but let's get rid of that for now. And then I didn't draw the entire connection from the stomach to the duodenum. I want a little room there, but the duodenum comes around, so that's the that's a D. The duodenum there, and the head of the pancreas nestles right in there into the C loop of the duodenum. And then they always show this. Well, they show it. You know, they are correct that the tail is slightly higher up in the body. In other words, more superior than the head. But they show it going straight across like that, and then we see it in ultrasound, and it's like, shoom, everything just dives deep. Well, because the pancreas is doing two things. Not only does it have an oblique lie, but it goes, and so from inferior to superior, it's also at the same time, let's see, more superficial to more deep, or I'll just write deep, it's just easier. Deep. So not only as it go inferior to superior from head to tail, it actually goes from higher up, well, I should be careful how I say that, more superficial, meaning more towards the belly, to deep, which is more towards the back. Daughter's high school, nonstop. And so that's why this is deep down here, and this is superficial up here. Okay. Let's make sure I'm on my notes. The head is most inferior, nestled in the C loop of the duodenum. Check and check. Then the head also has a uncinate process. Let's write that down. Uncinate. Whoa. Well, I tried. An uncinate process. If I could draw an arrow to here, that would be the uncinate. And then on this picture, that would be the uncinate here. It's getting a little messy though. I don't want to mess things up. The uncinate is that little part that sticks out. It is, so a lot of times, and this is relevant for your own knowledge, but it's also, honestly, it's relevant because this is just a standard question on tests and on registry examinations when you describe where something is in relation to something else. And so let's describe the uncinate process is anterior to the IVC. Okay, so anterior meaning it's more towards the top, more towards the belly, whereas posterior is more towards the back. And so this is IVC here. And of course, this is aorta there. Is anterior to the IVC. It is posterior to the superior mesenteric vein. Now, I always have a hard time with that. I actually have something right, here we go, right there. I put it over on this one, but it's just the same. When they say that the uncinate process is posterior to the SMV, they're saying right, I don't want my other color here. They're saying this right here is SMV. That might well be the truth. When you really anatomically take a person apart and very carefully look, that's probably SMV. But just remember, guys, the SMV and the splenic vein come together at the same point. And so it might be SMV here and move half a centimeter up the body, and it's no longer SMV, it is now the confluence of the two vessels coming in. So it gets a little confusing. You might be like, well, Mr. S, you said that's the confluence. It is. Technically, if we were really closely going to look at it, it might be more SMV than confluence, but we're talking half a centimeter or less away. So anyways, SMV, how about this? I'll do SMV/confluence. I'll just do CONF. SMV/confluence, but we'll circle the SMV because that's what the book is saying. Okay. I'm going to get rid of this guy there. Okay. More relationship anatomy. Relationship anatomy, when you get to that part in your textbooks, always read through it carefully and try to really think what that means. It's hard to do. It's really hard to say anterior and superior and to lateral to this. And sometimes even after doing this for years, I'm still like, is it really that? Really? Sometimes I question the book, but I'm not an anatomist. But okay, so the body and tail, the anterior and superior surfaces. So anterior and so these two images have, on this image over here, this is definitely the, let's see, anterior surface all around here. And I say it's definitely the anterior because our transducer is up here looking straight down. Whatever you run into is got to be anterior because you're looking from the anterior. On this image, it's a little more confusing. We think it's the same picture, but it's not. This is not necessarily the anterior surface. Let's see, I might point an arrow to there. That's not necessarily anterior surface. It's actually the superior. Because these two images are not from the same perspective. This is really a coronal image. In other words, it's the image we would see if we had perfect X-ray vision. If we were Clark Kent and we could look down into the body, this might be the way we look at things. And this surface now, instead of being anterior, would be superior. In other words, closer to the head. Whereas this image is a transverse image of the body, and so that's anterior. Just so you know. All right, so the body and tail, the anterior superior surface has stomach. Well, that's more superior. Has stomach, duodenum, and I have a big question mark. You know what I was saying? I sometimes question the book. I am really not understanding how the duodenum has a anterior or superior, I guess right here. Maybe this is what they're talking about. The duodenum starts right about here. Let's just circle right here, and that would be a superior surface of the head. Maybe that's what they're talking about, because once we go around the corner here, we're certainly no longer anterior or superior. If anything, we're now inferior. Okay, duodenum, and then left lobe of the liver. Well, yeah, left lobe of the liver is superior and actually anterior, because I could draw the left lobe of the liver here. I could also draw it over here, but obviously I haven't given myself enough room. The body and tail, and then it goes back to body in the book again. Anterior to, oh, okay, well, it's anterior to. Body, so body, let's see. Sometimes people call this a neck right about here, from here to here, the neck. And then body would be about from here to here. And then tail is from there to there. So that's tail, that's body. Little bit of a neck right here, and then head. The body is anterior to the aorta. And this little circle here, of course, is the SMA. The left renal vein, oh, I didn't draw that one in. If I did, it would look like this. It would come up here and squeeze, just barely squeeze through. Squeezing through right there. That could be that little thing I just drew right there is the left renal vein. Not necessarily all in the same exact picture, but we can see. I'll show you some of this on some of our transverse imaging. Oh, what else does it say? And most importantly, the splenic vein. So this big blue line, of course, it's not blue. It's black or anechoic on the screen, but I made it blue because it's a vein, of course. This big blue line lies perfectly underneath the pancreas. In other words, posterior to the pancreas. In other words, if we were to draw it over here, let's get that guy back up. Well, I kind of made it look like it's on top of this, but really it's below, it's posterior to that. So I can't draw, let's see, let's just do, no, I'm not going to waste your time. I can't draw the splenic vein down here on this picture because that would show it inferior. It's not inferior, it is posterior. Okay. The neck is anterior to the confluence, and that's what kills me. They're saying the uncinate process is posterior to the SMV, but then the neck is anterior to the confluence. That's why I get very crazy about this. Is it the SMV or is it the confluence? Here's a big question mark right there. And that's why I also say it really doesn't matter. The only problem is that it might matter on a test one day. Not a test. I won't mess with you, but I just hope I hope it's crystal clear if they ask you on a registry, because I don't know how else to tell you. The tail is posterior to the stomach. Well, okay. We have over here we have stomach. Well, that's kind of more superior, but it's superior, and then stomach. Yeah, if I were to draw a stomach in it, it would kind of come all the way down here, and then comes across. I know I'm making that. So yeah, posterior to the stomach, and also even medial because of the way everything is shaped in there. Let's see, posterior to the stomach. You know what? I don't know what anterior. Oh, it's anterior to the vein. Okay. It's actually, some books will say, so they're saying the tail is anterior to the vein. Well, but look at this configuration, guys. A lot of books don't say that the tail is anterior to the vein. Look down here. The tail's not really anterior to the vein. The tail is lateral to the vein. If this is the vein, well, this is the vein. Anything off to the side is lateral. So you could say the tail is anterior. You could say, all right, let's look straight up. Yeah. So if it fulfills two different parameters, both anterior and lateral, we call it anterior-lateral. Anterior-lateral, because it satisfies both the anterior and lateral aspects. Oh, it is what it is. That's messy. Okay, well, okay. So basic relationships, basic, well, we haven't even finished really basic anatomy here, but let's move on to acini. It's interesting. This is both an exocrine and an endocrine gland, and the acini are really similar to acini it's the same term used in breasts. Breasts produce milk. The pancreas produces pancreatic juice or enzymes. Same word. And actually, acini, is it the same word in lungs? I'm not a lung guy. I think it is the same word in lungs. I'll stop before I get myself in trouble by saying something else wrong now. All right. So the acini are these little outcroppings. Of course, there's cells all around each one of these little half circles here. There's cell. And those cells are the exocrine cells of the body, of the pancreas. We'll learn I'm losing my okay, yeah, you know what? I don't have that terminology in front of me. So the exocrine cells of the body produce enzymes, for the most part, enzymes that go into these acini, down these little ductules, into a larger duct, and eventually down into another duct, which actually we're going to talk about now. Didn't leave myself a whole lot of room. I'll use this guy here, because we have at least some ability to see what we're trying to look at here. So this small duct will drain into the main pancreatic duct, which I have drawn here. Usually pretty hard to see, but sometimes we'll see a little bit of it. If it's easy to see a pancreatic duct, that's a warning sign right there. It shouldn't be easy to see, you know, maybe in the future with better equipment, but as of right now, it should not be that easy to see. This is the main pancreatic duct, also called the duct of Wirsung. Wirsung, that's, I'm sure, someone's name. And as you see, and we've talked about before, it actually comes down, connects to the common bile duct at the ampulla of Vater, and then both the bile and the pancreatic juice are both released into the duodenum at the same time. And remember, that's with CCK. Oops, no, anyway. CCK is released, and that relaxes the sphincter of Oddi, and common bile duct bile and pancreatic juice come down through here. There is an accessory duct that does not attach to the common bile duct at all. It's simply pancreatic. And that, let's see if I can, this is the duct of Santorini. The duct of Santorini that's the accessory duct, not the main duct. And we rarely, we will rarely, pretty much never see the duct of Santorini because it is smaller, and it'll never have, well, I won't say never, but it'll never have a bile stone in it because it's not connected to the bile ducts. It could get calcifications for other reasons. All right. So still on kind of overall anatomy here, let's come back to this guy. We have the acini cells here. I got one image right in front of the other, or one screen slightly in front of the other, and it made it really hard to coordinate. Let's just make this yellow again. The islet cells, let's do the whole thing. Islet, as in island, cells of Langerhans. Langerhans. This is the endocrine cells of the body. So they don't put anything into the acini or into the ductwork. These are endocrine hormones. So the acini over here, they create enzymes. The islet cells of Langerhans create hormones. The blood supply, and you know what? I don't have, yeah, I do. I have something for blood supply. It's just not great. But we've talked about this before, so we don't have to get too much into it. Maybe I'll try to draw on top of this because the blood supply is not terribly well seen here. Let's make this red for. Have you guys had just thousands of mosquito hawks this summer? Holy cow. Okay, blood supply.
Last summer, maybe.
Oh, last summer? No, for me, it's this summer. Everywhere. Gastroduodenal artery, it's hidden behind the duodenum here, but remember, a common hepatic comes this way, and then here's our GDA, comes down, and we see that, and we see it coming kind of poking through the top of the head. The gastroduodenal artery, it has a branch off of it. I believe it would be this branch here, and little branches off there. That's, let's see, let's do this over here. GDA, it's hard to write, goes to the, this is a big word, pancreatico, pancreaticoduodenal. All right. Well, I know you can't read that. GDA to pancreaticoduodenal artery. And so that would be this guy down here. And then there's the SMA has a little branch off of it. And that's going up this way, and that's the inferior. So SMA, I'll go ahead and write SMA, but, you know, and I'll just write inferior. Zoomed way too much. I can't write. SMA to inferior pancreaticoduodenal artery. So that's one way of feeding it. And let's see, what's the other? Well, the splenic. And I mentioned before that, of course, this is feeding the spleen, but there's branch, all these little branches down here. I want to say, no, that's good. That's good. So that's our blood supply. Okay, now I think we're done with anatomy. In fact, let me erase. I'll erase this just because it's ugly. Okay, so quick review. So uncinate process down here. Interesting thing about the uncinate process is that sometimes it could be a different echogenicity than the rest of the organ. And I think part of the reason is that it actually grows from a different bud of tissue. And we're going to talk about that in a second. But that's the uncinate process down here. You can see on this picture how the splenic, and this is our X-ray view. We're looking straight at the body, not our ultrasound view. And you can see that the splenic vein runs behind, posterior to the organ here. The splenic artery is somewhat posterior, but also more superior. So this is on this picture, superior up here, inferior down here. Let's see, this is of course the head of the pancreas, kind of the head comes around. We'll just kind of circle that in red. This is the head. If you're going to say there's a neck, it's only right about here. And then body. And gosh, you know where the body exactly ends and the tail exactly begins? No one knows. It's a mystery. But there's our body and there's our tail. It has drawn in here the main duct is drawn. It kind of does a jiggy-jaggy, but that's all right. Along with the common bile duct coming in here. They didn't draw in their other duct of this kind of dotted line over here. That's our duct. So duct of Santorini, duct of Wirsung, common bile duct. Okay. So there's a couple of anomalies, and both of them have to do with the fact, and this is very common in the body. Let me back up just a little bit so I can hopefully write a little more clearer. This is, you can see at the bottom, I should have just left it there, is pancreas divisum, which is really weird because I always would have thought that it would be divided. But it's actually a normally shaped pancreas. I'll just write divisum, yeah. But the main pancreatic duct kind of goes right out where the duct of Santorini should be. And then you have this, what they call a ventral. Why would that be a ventral duct? Why would they call it ventral? Why would it call it ventral, guys, when really that would be the dorsal, like my body, our bodies, the dorsum is down here, the ventrum is up here, anterior, posterior, same thing. Yeah, anyway, in any case, these two ducts are kind of turned around here. That's pancreatic divisum. And I'll tell you how that happens at the same time that we talk about this next one. And an annular pancreas. So both of these guys, and you can more clearly see it here, in development, pancreatic tissue starts in a couple different places. And so I can't remember exactly how they move, but let's say we have some embryonic tissue over here. This is supposed to become the uncinate process, and you have more tissue over here, and that becomes the head, and maybe this tissue that was over here, and that becomes the tail. And all of these are supposed to grow and travel through the body. The cells actually migrate and create the pancreas. Well, sometimes that migration fails, and maybe you get part of it over here, and then part of it over here, and then that part goes to where it's supposed to be. But now you have failure of migration, and that failure of migration causes the pancreas to surround the duodenum. This is higher. This has a higher association with other anomalies and syndromes like Down syndrome. One of the things we learn about in Down syndrome is that we call it the double bubble sign, and that's when the stomach of the fetus, the baby, is filled with fluid, and then the first part, and there's a muscle right here, and then the second part of the very first part of the duodenum itself is filled with fluid, so you have a bubble and a bubble. And so that's one thing we see in Down syndrome, and Down syndrome is one of the associations you see with an annular pancreas. With divisum, same thing, a failure of two different buds to completely join. And so even though this exterior looks normal for this pancreas, by not completely and utterly joining together, these two did not grow as they should. The book also mentions ectopic. Anything that is ectopic pregnancy is a pregnancy in the wrong place. Ectopic pancreas, it's probably not the whole pancreas. It is probably these little bits that should have grown over, that should have grown this direction, gone, traveled, migrated to that direction, instead migrated the wrong way. And there's another number of locations. I believe it could actually be on the wall of the stomach, kind of a weird place for it, duodenum. And by the way, you are not going to find these, certainly not in the GI tract, because it says small intestine, stomach, duodenum, rarely in the gallbladder, liver, or spleen. Well, those you actually, in the spleen, well, yeah, okay, the tail, instead of growing and migrating there, it migrated and went right into the spleen, which is over here. And so now you have an area of ectopic pancreatic tissue inside the spleen. You'll see that. I mean, you'll never, I would be shocked if anyone looked at that and said, oh, there's that ectopic pancreatic tissue. You would just simply say mass. Or same thing with the liver or even gallbladder, they say it's so. But in any case, all of those ectopics are rare, and it would be very difficult for a sonographer to find it and impossible for us to diagnose it. Okay. Before I go to physiology, let me just let me zoom in on this guy. Um, okay. Let's see. Let's get some nice purple ink here. I don't know why there's two things down here. Maybe this is a slight anomaly, or maybe I'm just catching something funny, but this is basically, we call this the common bile duct, the CBD right there. But you know, if you think about it, it's actually it's the CBD which came this way, but it's also the main pancreatic duct. Common bile duct, yeah, it's the main pancreatic duct, common bile duct. Both come to that location. We always say CBD here, but it is what it is. I don't see this person's GDA, and that's okay. Maybe I don't think that's it. But let's just. It doesn't really matter. GDA could be there, it could be there, it could be all around. But in any case, if we find a little circle up here, there's our GDA. This is, remember, this is anterior, posterior. So we're looking straight down. This is the anterior surface of the pancreas. Head, uncinate process here. Let's see, that uncinate process, yeah, it's pretty much anterior to the aorta. Oh, and look here, the IVC is shaped like this. Well, it's being squeezed out. It is a vein after all, but it's also, we don't see it, but trust me, it's there. That is the left renal vein, is coming from the renal, the kidney here, and going up and over and into the IVC. Curiously enough, no SMA on this person. Now it has to exist. You cannot go through development without an SMA. So it exists. Perhaps on this person, it's just 1 more centimeter down, and then we'd find the SMA. So that's not an anomaly. It's just normally we do see it by now. Head, neck, body, and tail. Oh, we're going to get to a point where the book says that the tail is thin, and I'm sure it is, but it always seems thicker to me. Let's see, body thickness, head thickness. It's shadowed out, so it's hard to say, but that tail, for me, the tail always seems wider than the body, and your book says it's the other way around. That might very well be true. It might just be an illusion that the tail is always larger. Oh, this is a great picture, by the way, just so you see it. So aorta, look at that, right renal artery coming off and going underneath the IVC. Now, obviously, I can't see it either. I'm just making it up at that point, but it's got to go that direction. Okay. Physiology. Now, here's where I got a lot of writing to do, and I'm hoping this works out. Okay. So, physiology, the endocrine system. This is the hormones. Let's write that down. Hormones. They're created by the islet cells of Langerhans. Those are interspersed between the acini, but not attached to the acini. Well, why? Because they go straight to the bloodstream. They're hormones. Beta cells. These are the ones who create insulin. Extremely important that we have insulin. If you don't have insulin, you are a diabetic. Insulin is released when the blood glucose level is high. So when blood glucose, and remember, glucose, that's the sugar of energy. That's the sugar that you're going to actually use to move muscle. When blood glucose is high, insulin is released. What the insulin does is well, how do I want to write this? Blood glucose, when blood glucose is high, insulin, and let's just do this, released. Insulin is released. After it is released, glucose is converted to glycogen and stored in the cells, liver being the largest storehouse of glycogen in the body. So insulin gets the blood, reduces your glucose levels in the blood. Let's just go ahead and mention type 1 diabetes mellitus, DM. Type 1 DM. Autoimmune. Can I even write that? Autoimmune disorder. It destroys its own B cells. I'm going to X mark and destroys B cells. We don't know why this happens, and this happens to otherwise perfectly healthy individuals, and they become type 1 diabetics because they don't produce insulin in the first place, so they have to take insulin. Type 2 is generally mostly people who are obese, who have too much sugar in their diet, and what happens is they become insulin resistant, and so the body has just had enough of it, and now the pancreas is producing insulin, and still the glucose is not being removed from the blood. Glucose, by the way, guys, and this is my soapbox on sugar. Sugar is deadly. D-E-A-D-L, yeah. Sugar is deadly. It causes atherosclerosis. So if you want to find someone with plaque, well, try someone with diabetes. They're more likely. So athero, it's bad for your arteries. It's bad for your nerves. You know what? I'm going to spell out a different word. Nephropathy. Diabetics will lose their feet. First, they lose sensation. They get that pins and needles feeling in their feet because of nerve damage. And then they lose their feet because of atherosclerosis. And then they lose their eyesight because it's bad for their retina. Oh my God. That reads retina. It's in the back of your eye. And kidney damage too. I'll just write over here, kidney. So this is, diabetes is bad news. So if you have someone in your life who has diabetes, make sure that they are, if it's type 1, first of all, any diabetic should be on a low sugar diet. Type 1, just make sure that they're taking their insulin. Type 2, what do we do for type 2s? I guess give more insulin. Okay, so that is, I think, everything I want to say about beta cells. Those produce the insulin. They take your blood glucose and lower it. So when it's high, it's released. Glucose goes to glycogen. Glycogen is, remember, that's the storage. Storage, mostly in the liver. Type 1 diabetes is an autoimmune. Type 2 is insulin resistance and sugar bad. Okay. Alpha cells, they create glucagon. Alpha cells create glucagon. That does the opposite. So when blood glucose is too low, glucagon converts glycogen back to glucose, so we could actually use it. So you don't want your sugar too low, otherwise you'll get the shakes and you'll feel weak because you don't have enough energy in your blood feeding your muscles. And then delta cells, they produce somata. Draw that anyway. Again. Somatostatin. I'm sorry about that, guys, today. Somatostatin. That actually it's an inhibitor. That inhibits both glucose and insulin, and not to mention human growth hormone, thyroid stimulating hormone, and some others. And gastrin, which gastrin being a little more relevant to this conversation because gastrin is another hormone like cholecystokinin that's released by the intestines. But that's an inhibitor, and the reason we have inhibitors is to not allow anything to go out of control. So somatostatin is not the only inhibitor we have in our body, but it kind of says, okay, we don't need to make let's not make too much glucagon or too much insulin. It just inhibits all around. Let's finish up this part here, and then we'll take a break. The exocrine function, let's do a different color for exocrine. Ooh, let's make that kind of green like bile. That's our pancreatic juice. That's just a common term for it, not really necessarily medically correct, but pancreatic juice, mostly enzymes. If you guys remember what an enzyme does, it's simply it's a type of protein that attaches to another protein and slightly changes the configuration of it. By changing the configuration, that chemical reaction is suddenly a lot easier. So an enzyme makes chemical reactions happen. If it weren't for enzymes, the chemical reaction would be way too slow and we wouldn't be able to digest anything. So we have amylase. Amylase attaches to carbs, complex carbohydrates. I'm just going to write carb. It helps break down complex carbs into simple carbs. In other words, complex sugars. Let's do that. Complex sugars down to simple sugars. Lipase, well, everyone's heard of liposuction. That helps digest fat and breaks down the fats. And then we have trypsinogen and chymotrypsinogen. Both of these break down more proteins into amino acids. Now, if you've read that paragraph, it's a little confusing in the book. Because the author talks about pre-proteolytic enzymes and proteolytic enzymes. Pre-proteolytic enzymes are what the pancreatic juice is filled with when it is still in the pancreas. So trypsinogen and chymotrypsinogen, pre-proteolytic means it's inactive. There's something attached to it. There's something attached to this enzyme that's like, let's say it's trypsinogen. And actually, let's say that's the enzyme itself. And here's my little attachment right here, a little bit of protein that sits there. Well, this little bit of protein keeps it inactive. And once the enzyme comes out through here, through the head of the pancreas, bam, now it's in the duodenum. It then becomes proteolytic. This inactive piece is now removed, so that proteolytic is active. Well, that's super important. Here, we'll put another little piece on chymotrypsinogen as well. So both of these are in the, with these green little things on them, they're in the pre-proteolytic state. Then I'm going to come through and remove that. Once I get into the duodenum, now they're fully active. The reason this is important is because this organ is perfectly capable of eating itself. That is what pancreatitis is. The organ is consuming its own self because these enzymes are super, super powerful. We'll finish up on labs and I'll give you a break because it's pretty easy. Amylase. Increased, well, that's a sign of pancreatitis. This guy's got pancreatitis over here. Lipase. The book goes in a little more detail. I'm not going to. Amylase and lipase are increased. You have a good chance that you have pancreatitis. Fatty stool means that your lipase is not active or not going into the duodenum. So fatty stool is also another lab, I guess, or sometimes the doctor asks, did you notice literally fat globules or like almost like oil on top of water? Did you notice that in the toilet? Yes, no. Or they could actually do labs on it. And liver function tests. The LFTs will actually be increased with pancreatitis because the pancreas and the liver are so closely related, not only physically, but they work together. So when one is upset, the other one feels bad and gets upset with it. Okay, let me quickly look at. Actually, there was just a little bit more I wanted to say. So both in the amylase and lipase, I wasn't going to get into detail, but this is basically both of them are going to be injury to cell, and that could mean you went out on a binge alcohol. Too much alcohol will cause pancreatitis, or some viruses can cause pancreatitis. So injury to cell or obstruction. So we got a stone down here, or we have a mass down here. Either way, you're obstructing the you're obstructing the duct. It could only, for some reason, it could only stay in a pre-proteolytic state for a set amount of time, and then it starts to become proteolytic, and it will start to eat its way right through the side of the organ. Chronic or loss of tissue. Yeah, okay. Okay, let's take a break. What time is it? 2 o'clock. That was a long time, and honestly, I got to take just a couple more notes on the last 2 pages of the book I forgot about, so 15 minutes should be good. All right, see you at 2:15, guys. Okay, so anterior, posterior diameter of the head, 2 to 3.5 centimeters. Body, and your book says 2 to 3 centimeters, so I'll write that up here if we can see it. And I'll go back to my other color here. 2 to 3 centimeters for the body, and then the book, and I don't mean to say that in such a critical fashion, but actually, yes, I do. And the book says the tail is 1 to 2 centimeters. I am going to put a question mark on that, because this is a beautiful picture. You guys, we don't normally, this is the hardest organ for us to see, by the way. I don't think I mentioned that. We're seeing this one beautifully because, one, it's probably, well, it's definitely a thin person. It's probably a kid, and there's liver sitting right on top. There's no stomach in between here. The stomach's on there's a little bit of stomach right here, but there's no stomach. That's a beautiful picture. It's usually not this good. You can clearly see that this tail is wider than the body here. So I would circle that question mark. Besides, it doesn't, I'm not overly concerned about this discrepancy, this obvious discrepancy. The #1 measurement is the head. That's the #1 measurement that doctors look for. All right. Oh, and we got something else going on here. Let's add, let's give it a green color. I got to draw it in since we can't see it. That's pretty normal. We can't see the duct of Wirsung here and the accessory duct there. I guess I could have used a different color, but it is what it is now. And let's use yellow again. No, let's use orange because we want to differentiate this a little bit. Gosh, it even gives us a measurement in the tail, and actually I didn't write it down. But here's where we normally see it, and that's about midway. So when we do see the duct of Wirsung, we usually see it in this area. Well, why? Because it's perfectly perpendicular to the sound beam, and so sound is our anterior, posterior, our axial resolution is good. Our beam is bouncing off nice and clean. This is what, 2.5 millimeters. So up to 2.5 millimeters is considered normal. So anything beyond that, abnormal. So if it's 2.6, that's borderline, it's abnormal. 3, definitely. And then it also gives a measurement here, and I actually never really considered this measurement, to be honest with you. But so in the head of the pancreas, still the duct of Wirsung, not the accessory duct here. They say 3.5. I did, yeah, millimeters. Millimeters, right? And then it talks quickly about what it looks like. one of the reasons why this is either a thin young person or even a pediatric patient. Reason I say that is look at the echogenicity of the liver and the pancreas. Those are, on this person, they're identical. Children and thin people, young adults, but even thin, let's just stick with young adults who are thin. Children who are thin have hypoechoic parenchyma, hypoechoic organs. You start getting either a little heavy or a little bit older, and we start getting fat deposits inside of our pancreas. So it is completely normal, and that's another hypoechoic pancreas right there. It is completely normal to start getting little fat deposits, and like these little echogenic dots around here, that could be just a little bit of fat depositing in. So the echogenicity can go up as we get older and or heavier. So, but even a thin person who's let's say 40 years old, they're not going to be terribly hypoechoic because they're 40. And then it can go to just outright echogenic, but that usually is in the case of chronic disease. But these guys can be very difficult to see. Sometimes you see the echogenicity here. This is basically probably, well, this is fat here around the SMA, fat and connective tissue, same difference. This is in stomach, intestines, fat, whatever over here. Sometimes the pancreas can perfectly match that color, that echogenicity. Then you have a hard time, really have a hard time seeing the pancreas even when you're looking right at it. So in other words, wide range of appearances of the pancreas. Okay, let's go into disease. Cystic fibrosis. Cystic fibrosis, people with cystic fibrosis have all sorts of problems with any mucus that's created in the body, or any mucin that's created in the body is overproduced. So lungs, we all produce mucin in our lungs. People with cystic fibrosis have way too much, and they could pretty much almost drown in their own mucin. So they have to go through a lot to make sure that they remove that from their lungs. Pancreas. I don't know why the pancreas itself produces mucin, but it produces enough where the pancreas can be affected. People with cystic fibrosis, and so you see a young person with an echogenic pancreas. So cystic fibrosis, gotta make an echogenic pancreas in a young person. Maybe I should just put pediatric, that'd be easier. If you see an echogenic in a young person who has no other evidence of pancreatitis, they probably have cystic fibrosis. Of course, if they have cystic fibrosis, they know it. There's no keeping that from the person. Moving along, is there anything else I want to say? No. Echogenic, they tend to be small. Anytime we assault the pancreas over a long period of time, it becomes atrophic, smaller. I'll write that down in a second. Acute pancreatitis. Let's pass by this phlegmon here. Phlegmon. And look at these two guys here. Now I had a young man, 14 years old, and the head of the pancreas was about that. Actually, is that? Wait a minute. Oh, no, no, no. The head of this person's pancreas does this. But my patient had one that looked like that. You know, the whole head was like that big, and the body was pretty large too. And I was all concerned. I thought he had cancer and all this stuff. He did have jaundice. Well, he had jaundice because bile can't get out of the liver with a large tumor like that. He had pancreatitis because pancreatic juice can't get out of the pancreas with a large mass like that. That for him though, it wasn't a mass as much it was focal pancreatitis. This person on this image here has diffuse pancreatitis all the way down there. It's interesting how this pancreas doesn't dive down like they normally do. I can't explain that, but can't always explain everything I see. Granular appearance, heterogeneous appearance. So that's definitely right. Heterogeneous is a possibility. The arrow, well, I'll just use the arrows that are already there. Fluid. These arrows are pointing, so there's a little bit of peri. Let's just write that. Pancreatic fluid, peripancreatic fluid. So that could literally be pancreatic juices are just going right through the side and into the, well, let's see, that would actually be kind of, well, probably still retroperitoneal, because this looks like there could be peritoneum right here, or it could be in the lesser sac. Remember, because the pancreas sits in the back, lesser sac, then stomach / liver. So if it were to be go from the retroperitoneum, it would go into the lesser sac. I guess this is now. I know I told you like 20 times so far that the pancreas doesn't have skin. It doesn't have a fibrotic covering. This is why. Imagine this. Imagine the pancreas has a nice fibrotic capsule glycine type covering around it, and we get pancreatitis. As bad as it looks, having pancreatic juices oozing out of the side of the organ, it would be worse if they got stuck in here, because at least by leaving, they're just eating up around the pancreas. But if they were stuck inside under this make-believe fibrous capsule, the entire organ could be destroyed with one pancreatic attack. So it's actually really important that the pancreas is able to weep, as it were. Okay. So acute pancreatitis, let's see, the most common reasons for it is either, they say gallstones, but let me tell you something, guys. A gallstone sitting over here in the gallbladder is not going to cause pancreatitis. A gallstone that has gotten into the common bile duct and got stuck right there at the ampulla of Vater, or more specifically, couldn't get through the sphincter of Oddi, that is going to cause a backup on the duct of Wierson. And if that duct cannot empty, then the juices flow out of the duct and into the tissue. And like I said, normally the juices are in a pre-proteolytic state where they do not eat its own tissue, but for some reason, when it sits in there for a long time, it becomes proteolytic. In other words, active, and it actively eats its way out. So an obstruction from a gallstone down here is a possibility. The other is ETOH, ethyl alcohol. In other words, booze, but not, I'll actually write another word, binge. Was there an E on that? No, it's Bing. Now it's binge. Okay. Drinking heavily really hurts your liver and your pancreas, but probably more your liver. Binge drinking, where you go out and just get annihilated. You just get annihilated one night. And even if it's your first time drinking or you're not a heavy drinker normally, one good solid binge drink can cause pancreatitis. And here's the bad news, guys. You get pancreatitis once, you're going to get it again. So be careful with the binge drinking. And don't talk to, never mind. I'm still green from the last time I did that. Okay, so here's another acute. This one looks a little different, but once again, some pancreatic fluid there. And just kind of a fuzzy appearance, but in and of itself, this doesn't look that abnormal. The fluid here is definitely abnormal. That should catch your eye, but the organ itself, this is a hard organ for us to see, and so this might be a little bit of fluid down here too. But if you didn't see those fluid pockets, you might just say, okay, yeah, pancreas, and keep moving on. Of course, if you had your labs, then you would say, no, that doesn't quite look right. We're going to call it pancreatitis. What else did I want to say about pancreatitis? Enzymes in blood spill out of tissue. There's no fascia. I already mentioned that. Oh, blood. It's bloody too because if you're eating tissue, you're eating blood vessels. So it's literally tearing right through everything, including the blood vessels. So the blood and enzymes get on the outside. Remember, the splenic vein is running down here. Oop, well, these enzymes can go through and cause damage to the wall here. It can cause thrombosis of the splenic vein. So now if you get thrombosis of the splenic vein, your spleen increases in size. You look like a giant spleen. So you can get splenomegaly from thrombosis of the splenic vein. This is looking ugly. A phlegemin is a possibility. I've got a picture of that in a second. And your white blood cell count will go up as well because you're basically inviting infection with all of that damage. White blood cell count, of course, goes up with infection. This is a phlegemin. Phlegmon. I always add a syllable in there. Phlegmon. This is one of the best pictures, and it's always the one I find on the internet when I'm looking. And it is inflammation that travels through the tissue, usually along tissue planes, like well, in this case, it could be along the omentum. And it causes just overall very, this is like, I'm going to call this severe, I've lost my train of thought. Edema. This is all edema. It's tissue, but it's super thickened tissue. And I do believe in this person, I do believe this entire section from here to here is omentum. At least that's the most likely thing for it to be. And normally the omentum is very, very thin. So Fleischmann is a possibility. Oh, well, right. The other possibilities. So once fluid starts coming out, you know, this is a small amount of fluid. Well, it can be more than a small amount. It could actually be a pretty decent amount. Where did I put? There we are. Okay. I don't like that color. Let's use green, prettier. So this person has a very thick okay, well, that's strange. I'm not sure why it's I can't write on that one. If I find it, I could write on it. But that's it. Finally, whether we call this tail or body, I guess body is more. I guess we call that tail. You can measure from there to there, there to there. Very enlarged, edematous. And look at this here, off the backside. There's this fluid. We call these pseudocysts. Pseudo because they don't have a real wall. A cyst has to have a wall in order to be a cyst. They don't have a real wall, but they can be walled off, interestingly enough. Now, first of all, they don't. We know enough now that, well, like the tail of the pancreas, well, you might be retroperitoneal, you might be intraperitoneal, because there's that one little tip right there at the splenic hilum that is intraperitoneal. But in any case, we know that there's potential spaces. So this fluid's not going to travel very far before it runs into the edges of that potential space. So that's part of what keeps it cyst-like in one area rather than just simply moving all over the place. The other thing a pseudocyst is, it has very inflammatory substances in it. You know, these enzymes and acids. Yeah, there's a little bit of acid, I believe, in enzymes, acids, and that's pretty much the most inflammatory part right there. And the body does not like that. And so it walls off the pseudocyst. So this will eventually create, if it's there long enough, it will create a wall of kinds. It's more of a fibrous walling off of really nasty fluid here. So pseudocysts they're most likely to occur in the tail, but they could be over here. Oh, I was going to roll my picture, and that's it. Let's see the head. Yeah, so there's our IVC. Actually, it's kind of hard to figure out where the head is where the head actually ends on this one. But let's just say we could have a pseudocyst over here. We could have them up here. But the tail is number one. Inflammatory is walled off by body. Most are stable. Oh, right. And here's the thing about a pseudocyst. A large one is really dangerous. These smaller ones are not, they're painful, they're not comfortable, but they're not terribly dangerous. A large one is. Now, most are stable. I don't think this was in your book. Most are stable. Is it L or EL? Anyway, most are stable. If rupture, it can lead to shock and death. So they're stable, so that's good, but if it were to rupture and get into the peritoneal space, it can put the person right into shock. And the other thing I wrote down is that the book went into all these different appearances. Just it has a varied appearance. It could be completely cystic and anechoic. It could be almost solid looking. It really depends on exactly what's filling it up, how much blood is in the cyst versus how much just pure juice and enzyme. Chronic pancreatitis, I think I put this in the wrong spot. Yeah, I did. There it is, down there. A little out of order for that, but that's okay. Over time, chronic pancreatitis, that basically means multiple acute. So over the years, this person has had multiple episodes of acute pancreatitis. This person looks like little calcifications. Those echogenic, I'm still another layer. Oh well, it is what it is. Calcifications, sometimes the entire, the tissue itself is echogenic as it becomes more fibrosed. So we'll just say overall echogenic is likely. Calcs are likely. This person, you can see the duct of Wirsing here, although it's not exceedingly large. It's probably borderline. Oh, and they tend to be small. I've seen them where they are so small, I can see it, but I can't believe it. It's so thinned out. Small, another word for that is atrophy or atrophic. Cysts or small cysts are possible. And those could either be just retention cysts from the previous attacks, or just or backup, a small backup of fluid. And that was the last thing I want to say. Just like everything else that is chronic, not everything, but so many things that are chronic, a chronic irritation, we now have an increased likelihood of pancreatic cancer, and that's the bad one. Yeah. So let's talk a little bit about cancers. Neoplasm does not mean cancer. I think I've told you guys that before. Oh. Yeah. Oh, and my other pseudocyst was all the way over here. Wait. This pseudocyst, I'm sorry to go backwards, but I just saw that. I forgot about this picture here. Beautiful. Oops, kind of a bad drawing, but at the head of the pancreas, here's that uncinate process there. The head's kind of distorted. Left lobe liver, a little median left lobe liver there. Okay. Anyway, we can go away from that. That's all right. Actually, tell you the truth, this is a lot like what the that young man I scanned who had a tumor. It looked like a tumor on the head of his pancreas, except on him it turned out to be focal pancreatitis. But this person does actually have a tumor. You can see that the duct, the pancreatic duct, the duct of Wirsung, is very much increased in size. So interesting that the SMA is so far away from the aorta. I assume that's the SMA. I might be incorrect on that. But so that tells me when there's more separation than expected, that tells me there's something in here. Perhaps the uncinate process, or perhaps just part of the tumor is grown in between these two. Anyway, what is this here though? So one of the things it's very confusing. I'll just tell you right now. I don't know if that's what we're looking at. So this little area, it looks a little bit like fluid because obviously it's anechoic, but on the other hand, it kind of doesn't look like fluid. Just so you know, the most of the stomach is over here, and then it squeezes in between the liver and the pancreas. So what we end up seeing is multiple layers of wall, stomach wall, or duodenum wall if we're a little farther over. That's what I was trying to figure out, if that's what I'm looking at there, but I don't know. Like I said, I don't know everything. So what else do I want to say? Most common cancer, unfortunately, is the kind that, I mean, how many people have I known, or at least known of, I'm not a lot of close people, but where they get diagnosed with pancreatic cancer, and 2 weeks later they're gone. But the exocrine component of the pancreas is the most likely to get cancer. 90% of the cancers are exocrine in origin. And of those, the vast majority are just simply adenocarcinomas. Most of them are in the head. Most adenocarcinomas are in the head. The good thing about being in the head is that the sooner it causes ductal backup, common bile duct, duct of Wirsung, the sooner that happens, the sooner you get diagnosed. But the bad thing about having a tumor up here in the head is that, well, that's kind of where all the action is. And so it's more complicated surgery to resect that tumor. Now you have to connect everything back together. Let's see. Oh, yeah, and so the survival rate's not very good. 7% survival at 5 years. And that 7% are only the very fortunate few who this tumor was caught early on. Okay. Got that one. The endocrines are less likely. That's going to just drive me insane. The endocrine are less likely to occur. Those are going to be insulinomas. That sounds like probably a beta cell. What's next? Gas. Gastrinomas and the glucagon. The glucagonomas. So, far less likely. They have a much better, I had to look it up, but more like a 55%, at least in one study, 55% at 5 years. And whether it's 55, whether it's 60, whether it's 40, it's still, you're in much better shape if you have an endocrine, if you have one of these, insulinoma, gastrinoma, glucagonoma. Say that 5 times fast. I wanted to mention also, let's go back to our original colors so we can read this. There was a word in here that I want to make sure that we covered. Carcinomatosis. Kind of like Hakuna Matata, but carcinomatosis basically just means widespread. Widespread cancer. In other words, Mets. So why they can't just use Mets all the time and they have to keep throwing different words around at us, I don't know. But anyway. The other thing, if there is cancer, because a lot of times we might see a little something and we're not sure that it's cancer, but then if you see a lymph node with increased size or more hypoechoic than normal, that is also a sign that some kind of cancer, an adenocarcinoma or an endocrine cancer, is occurring. Okay, gosh, just 2 minutes, guys. The last couple pages, I have to admit, I kind of blasted through them. Because it just starts talking about the different types of cancers and how they look. And so, page 224, contradictory. Just so you guys aren't overly confused, on page 224, I'll read it, so you don't have to look it up right now if you don't have your book. Get my eyes on. Solid neoplastic lesions. Sonographically solid pancreatic tumors usually appear as ectopenic. That's a word that we don't use too often in America. That means kind of like sonolucent, we don't use too often, but it just means more hypoechoic or echogenic areas within the parenchyma. So in other words, they could be hypoechoic, they could be echogenic. Compared, and then it says compared to the surrounding pancreatic tissue, these masses are hypoechoic. Well, that kind of sounds like it just completely disagreed with the first sentence, because you're always comparing to the surrounding tissue. If you have a liver mass you compare the mass to the liver tissue. You don't compare the mass to some other tissue. So when we talk about pancreatic masses, we look at the pancreatic tissue around it and whether we call it hypoechoic or hyperechoic. But anyway, I just thought those two sentences did not coincide well, and I didn't want you guys to be confused with that. The fact is that solid tumors can look either way: hypoechoic, hyperechoic. Blood flow in them, so always use your Doppler. And those are the vast majority of cancers. Well, tumors in general, and cancers as well, are solid. The amount of cystic cancers are 1%. So the vast majority of cysts that you see on the pancreas are either simple cysts or pseudocysts, but they are very unlikely to be cancer. And this is really funny because when we get into, we're going to hear these same exact cysts when we get into GYN, gynecology. Serous cyst adenomas. Serous cyst adenomas, that means they're more filled with a serum, more of a clear fluid. These are benign, and they have many cysts. Well, here's another place where your book is a little bit confusing, I thought. It says less than 2 centimeters, and then like a page later it says too small to even recognize as individual cysts, which would be considerably less than 2 centimeters. But in any case, smaller cysts, multiples. But then, and this is, once again, just like the pelvis, you have a mucinous cystic adenoma. And just like in the pelvis, these are larger cysts. Now, your book says greater than 2 centimeters, and then I think on the last page or something, it says 5 centimeters, as if 5 centimeters was a requirement. But in any case, larger cysts. And if they're mucinous, they're probably going to have some echoes inside of them, because mucin is not completely clear, or hypoanechoic, I should say, on ultrasound. So mucinous cystadenomas are a possibility. The other possibility for cysts is polycystic kidney disease. So people with polycystic kidneys, I think we saw those the other day. Obviously, if it's polycystic kidneys, the kidneys have cysts. Many of them have liver cysts, and a few of them, about 10%, have pancreatic cysts. The pancreas will never have so many cysts as to cause a failure of the pancreas from polycystic kidney disease, whereas the kidneys and the liver can be affected because they simply get a lot more cysts. And then your book ends out with von Hippel-Lindau syndrome or disease. I think it's a syndrome now. And those people who have von Hippel-Lindau have multiple vascular tumors like hemangiomas and that kind of stuff all over the organs of the body. And so that means brain, liver, kidney, pancreas. And so if you have someone with von Hippel-Lindau, then you take extra care to try to find any kind of tumors there in the pancreas. And not that it would matter, because pancreatic tumor is probably not going to cause problems unless it's in the head, because von Hippel-Lindau. I don't believe von Hippel-Lindau, their tumors become cancerous. They just have dozens, if not hundreds, of tumors around the body. I know I blasted through those last pages. If you want to reread them, it might be helpful. My brain kind of went dead on that. Oh, quickly, and I'm gonna blast through this. This is what I do when I have too much time. It's funny this doesn't. Having too much time doesn't seem to happen to me anymore. Actually, oh, that's a nice anatomy of the pancreas. Extends on a horizontal oblique line from the side of the spine. Okay. I like doing this in PowerPoints. Kind of helps new students who understandably can't see this at all. It kind of goes back and forth. You're able to see that a little better. So that's the head, neck, body, and tail of the pancreas. There's the aorta and the superior mesenteric artery. And notice the surrounding echogenicity. Oh, and there's yeah, that's it. Yeah. Oh, I'm seeing it on my other screen. Freaking me out. Kind of a compressed IVC over here, but then the left renal vein traveling from from the kidney all the way up over, going across. So that's what that is there. It's always good to see if there's anything relevant. It's kind of cool. This aorta is normally quite round. We've got a little knob over on this side. That's the base of the right renal artery. And here's a beautiful left renal vein going all the way across and dumping into the IVC here. Oh, that looks like a familiar picture. That's for the pancreatic visum again. Normal. Problem, how big? Not sure. There's a tumor here. Not easy to see this tumor, but it's definitely there, and it's definitely causing a backup. So our first clue, if you can't see the tumor, our first clue is how it just is large, 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 and then just stops right here. And here's our tumor. And just a nice picture of all that. Why did I draw this picture? Oh. Agenesis. Your book didn't mention that. Complete agenesis is incompatible with life, so you will never find someone without a pancreas. If the body and tail fail to form, the head will experience compensatory hypertrophy. Pretty awesome. There's a pancreas division again. Oh, there's our annular pancreas. Probably a little better picture, showing how it squeezes the duodenum. Oh, and an actual image here. Hard to see, hard to understand, but we have pancreas on either side of the duodenum. The duodenum is partially fluid filled. This is probably a baby because you wouldn't be alive if you were an adult like that. Oh, how did I miss something? So glad we took the time. I skipped over this in the very beginning, guys. Sorry, we're gonna do. Let's just go over this real quick, and then let's see, what time is it? 3:10. Let's see. 1, 2, 3. Yeah, okay. Yeah, we won't spend too much more time. Sagittal picture. You got to know what the pancreas looks like in sagittal. We see it all the time. We just don't know that we see it. In sagittal, of course, we have our aorta here. We have our celiac trunk. I decided to put a little left gastric artery there just for fun of it. SMA. And look, over the mesenteric arteries are posterior. Let's see, because this is anterior. This is posterior. Inferior, superior. We have here the more or less the neck, the body, neck or body of the pancreas is sitting here over the splenic vein. I decided to draw a little bit of the splenic artery over here, so that this artery, this little circle, came off of here. We just don't see that happening. And sure enough, and those are those stomach, usually double stomach and then liver on top of that. So let's look a little closer at these two pictures, and then we're done. If I do a review, we'll go through that other PowerPoint as well. So here can I draw on this? No, of course not. Oh wait, was that there before? Okay. So A is for stomach. It's actually for antrum of stomach. So that's the stomach up here. Pancreas there. Splenic vein. It's not the confluence yet. We're a little bit left of center, or we're a little bit to the left of where the confluence would be. That would make this guy over here more or less a circle. That's our artery, our splenic artery. We don't see the celiac axis here. We barely see it, I guess. So that's a nice long image there, and even better image actually. We have our left gastric. Killing me, Smalls. I don't even see it. All right, well, left gastric artery here, celiac axis, celiac trunk there. The circle is the splenic artery, splenic vein. Here's your pancreatic tissue all around here. That's sitting up on top of the SMA. Remember that one picture I said I was curious that the SMA wasn't there? Well, this is why it's curious. I mean, look at this. This is the pancreas is here. The SMA should be behind the pancreas. It could be that this person's SMA started really low, or maybe the left lobe of the liver was atrophic and small, and so everything else moved up and their SMA stayed where it was. But in any case, we didn't see the SMA in that one picture, and that was a curious thing, but not exactly the, yeah, this picture over here, not exactly the, dang it. Yeah, where's that SMA? So it's kind of just an interesting little thing, but like I said, person wouldn't be alive if they didn't have an SMA, so it's somewhere. Okay. I think we are done for today. Let's do, we've gone through an entire chapter. So tomorrow we're not doing vascular, we're doing abdomen again. tomorrow, let's start off and let's go through this, even though this is not this is the last book. And I did a lot of work on these PowerPoints. And of course we get rid of the book, and now I got to start all over again. We'll go over this as a review tomorrow. And then, oh my God. You know what? Tomorrow is another easy one. So we started off, guys, with the liver, which was like 2 weeks. Gallbladder, which was 3 days. And we had some other things. We had the peritoneum and stuff, and that's actually were a couple of days each. Then we have some organs that just they don't do a lot. The spleen actually is probably the most boring organ that we have. And so that's a single day one too. So tomorrow we will start off, we'll do a little bit of review on the on the pancreas. I'm sorry, pancreas, spleen, pancreas. And then we'll do spleen, and I think we'll do the entire chapter again. For now, we're going to continue with daily homeworks. They're going to continue to be short. I'm not, depending on on when we go back. As of right now, I don't have any exams planned. I think that honestly, and you know, we're all human. It's just it's hard to do. It might not be the best thing for us. If I do an exam, this is how we're going to do it. It's going to be a speed exam. In other words, you have 20 seconds per question to answer. So that's a possibility if we do those. But as of right now, I have no exams scheduled. But I got to talk to Melissa right after this, so I'll talk to her and see what she thinks about that, because we are supposed to do some exams. So. I'll do small exams, little quiz exams. I know we'll call them quizzes. All right, you guys all cool? Do you have any questions? Was today too much, too fast? Might be. There's a lot of material. Oh, no answer. It must have been easy. Okay, we'll go even faster tomorrow. All right. I will.
Oh, I was gonna.
No, let's not go faster.